My talk this morning is about hemorrhage control and pelvic fractures. This is something that we've been interested in Denver for the past 30 years, and particularly with some new techniques in the last 10 years. I have no conflicts of interest. We recognize that the vast majority of patients that come in with pelvic fractures are fairly low mechanism and have, relatively routine outcomes. They get their pelvis fixated or get a plate, and they do fairly well. I'm really talking in this talk about the 8 to 10% of patients that have very high mortality rates and have significant morbidity related to their injury patterns. When we look at pelvic fractures across the board from a historical standpoint, we realize that mortality is really broken into thirds. About a third of patients die from acute hemorrhage, a third of patients die of multiple organ failure in sort of a delayed fashion, and another third of patients die from their head injuries. What's interesting, though, is that we recognize that there is a link between bleeding or hemorrhage and the actual number of red cells that you receive and multiple organ failure down the road. So although there is a stepwise increase in acute bleeding and the mortality rates, we recognize that some of that also relates to multiple organ failure with an increase successively with each unit transfused. And so I think that the take-home message that we really have come away with is that no matter which aspect of the mortality related to pelvic fractures that you're trying to address, you really need to stop the bleeding in these patients, both for early deaths as well as for late deaths. So we began to develop about 20 years ago a pelvic fracture protocol. I can't say that very well, a pelvic fracture protocol. And we've refined it over the past 2 decades to try and address these various different elements to stop the bleeding in these patients. So when your patient comes in, the first thing that you want to recognize is whether the patient is stable or unstable. If they're stable, they meander off into a separate group of patients, that 90% that get scanned and fixated and maybe have other injuries that need an intervention. This is that acutely ill group of 8 to 10% that come in and are hemodynamically unstable. Now, clearly, any patient that's unstable, we immediately activate our massive transfusion protocol, so we get blood and FFP and ratio delivered directly in our coolers so that we can transfuse these patients. And then we need to figure out where they're bleeding. Typically, patients who have pelvic fractures also have a lot of other injuries, particularly those that are unstable from their pelvic fractures. And so some of those first steps include doing the FAST exam, so you ultrasound the abdomen and the pericardium to see if they have an intra-abdominal source of blood loss. Check a chest film to see whether or not they have intrathoracic sources of loss. And then obviously you want to check a pelvis film and sheet the pelvis or do mechanical stabilization of the pelvis in the emergency department. And all of these are part of your diagnostic armamentarium to try and figure out which cavity you need to address or how many cavities you need to address in order to stop the bleeding in these patients. Now, some of the pitfalls as you start to evaluate these patients in the ED, here you can see one of my former chief residents who was very vigorous in evaluating the pelvic ring. So anytime that you evaluate the pelvic ring, it does not require a big press down to see whether or not that patient has an unstable pelvis from a geometric standpoint. So all that this nice resident, well-meaning resident, is doing is just reopening or re-breaking open that open book pelvis fracture. And so typically now, instead of just reopening it, if I'm waiting for x-ray and the patient is unstable and I'm trying to figure out if the pelvis is the source, I'll palpate that pelvis to see if it moves. It's usually pretty obvious if the pelvis is markedly unstable. Alternatively, you're going to check a film. Now, I will say one of the pitfalls I don't have up here is that when you check that pelvis film, remember that it only shows you where the pelvis is at that moment in the emergency department. It doesn't exactly tell you where the pelvis was when it got hit by the car. So the pelvis film can look remarkably normal and yet doesn't show you that it actually was wide open, and now when the patient is lying in your trauma bay is a little bit closer to its geometric size. The other thing that we have learned over the years is that external signs of bleeding, whether it's from extremities or other sources, also includes the perineum. There is no worse feeling than missing a big perineal injury in these patients when you make it up to the operating room and suddenly realize that a part of their blood loss is due to perineal loss. And here you can see this is what I've termed it a perineal degloving injury. It's where there is such a force in the perineum that the entire rectal tube simply pulls away from the pelvic sidewall. And here you can see, so this is the let me see if I can do this. This is the rectal tube over here, and this is this huge degloving injury that extends all the way up to the pelvic floor on the side of the rectum. Does that make sense? And so these can bleed significantly. This is not acutely in the ED, because acutely in the ED, this patient was trying to bleed out of his perineum. We packed his perineum, closed his legs, and took him upstairs. So as we move through our pelvic fracture protocol, one of the elements of it is quote unquote sheet the pelvis. Now for us, that really means sheet the pelvis. Some facilities have these fabulous binders. So you can see this is a patient that got transferred to us. He had this cool looking camo binder that I of course had to take a picture of. But this is the way that we typically do it, is we simply put a sheet right across the greater trochanters, and you can see, of course now I can't erase mine because I'm not technologically, but if you can see, actually rather than tying it in the middle to stabilize the pelvis, I actually pull the sheet all the way across, and then I fixate it with penetrating towel clamps on either side of the pelvis. That way you can get a nice film of your pelvis. Your clamps are on the side, and those penetrating towel clamps are a little bit easier to release once you're up in the operating room. The old-fashioned way that we used to do these is use C-clamps. The nice thing about this big C-clamp is that you could move it either down on top of the legs if you had belly or chest problems, or you could move it all the way up on top of your chest if you had lower extremity problems. Any way that you look at this, we like to do some type of mechanical stabilization for that pelvic ring while you're down in the emergency department. It splints the bone, it decreases the pelvic volume, and is fairly effective. Here you can see some pre and post binder films, and that wide open book pelvis is nicely closed down. Now there are some cons to actually doing this in the trauma bay. Number one, there's no data. So we're doing a therapy that we have no data upon, and yet we continue to do it. Because we feel that it does make a difference. And for those of you that have done it and seen the impact on the patient's physiology when you close down that pelvic volume, I'm at least marginally impressed by that. The other thing that you need to be cognizant of is to not leave that pelvic sheet or that binder in place for too long. Here you can see this patient ended up with a horrible, we actually had to debride this and do a split thickness skin graft to this area because this binder had been left too long in transport. Occasionally you get perineal palsies, and not all fracture patterns are really amenable to this sheeting. We recognize that those patients that have posterior element disruptions, as you close down that anterior portion of the pelvis, you actually can break open the posterior elements and may have some more bleeding. And so I think it's smarter, rather than simply pulling across the front, is to have someone push the pelvis in from both sides and then fixate the pelvis so that you're really just holding it stable versus really rocking those anterior elements in. So again, I'm going to march us through this protocol. Patient comes in, they're unstable, you activate the massive transfusion protocol, you sheet the pelvis, you make sure that you don't have a thoracic source, and you do your FAST exam. So this is one of the critical break points for us as we're taking care of those patients. The FAST exam tells us whether or not there's intraperitoneal blood, spleen, liver, mesenteric injury, something that we need to go operate on in this unstable patient. If that FAST exam is positive, and we actually, it's in press, but we feel that the FAST exam, particularly when it's repeated more than once in these patients with pelvic fractures, is reliable. I know there are groups out there that say it's not reliable. We actually feel that it is very reliable in those that do this routinely. If your FAST exam is positive, that patient goes to the operating room and gets a laparotomy, gets their spleen taken out, their liver packed, the mesentery taken care of, whatever is causing the bleeding in the abdomen. You reevaluate the patient in the operating room and decide whether or not they have now stabilized from their intraperitoneal blood loss, and whether or not they can go on to the ICU and get their scans done. Alternatively, for those patients who remain unstable, you look to see whether or not they have a pelvic hematoma. Usually those pelvic hematomas are really obvious. Big, bulging, may even be difficult when you first get in the abdomen. If they have a pelvic hematoma, then you know they still have ongoing blood loss related to their pelvic fracture, and they need some type of intervention for pelvic fracture related bleeding. If we back up on our algorithm and we're back up again at our FAST exam point, if those patients come in and they have an unstable, or they're hemodynamically unstable and they have a pelvic fracture but their FAST exam is negative, we trust the FAST exam. And if the FAST exam is negative, that patient merely needs an intervention for their pelvic fracture related bleeding that's causing them to be unstable. So what are our options to control pelvic fracture related hemorrhage? We have two basic options. We can either do angioembolization or we can do pelvic packing. So when you look at angioembolization, this technique has been available in many centers for probably 30 years now, and it is very effective in addressing arterial bleeding. The question becomes, though, how do we figure out which patient predominantly has arterial bleeding? Do you embolize patients who have a blush on their CAT scan? Do you embolize those that have a large pelvic hematoma on their CAT scan? Or do you embolize all patients who are unstable? Here, for example, is a CT scan that shows this quote-unquote blush related to their pelvic fracture. You can see a nice hematoma around it, a blush. The problem is, and this was a study that was just presented last year at the AAST and published this year, is that in those patients who actually have a CT scan that demonstrates that they have an arterial blush, only a quarter of those patients actually had a therapeutic angioembolization. So a blush alone, which you would think would be an obvious reason to go and embolize these patients, is not a de facto reason to go and embolize them. If you are going to send someone to angiography, you need to make sure that your angiographers or your vascular surgeons evaluate all of the pelvic vessels, and if you do perform an embolization, it's performed with gel foam so that those vessels eventually can recannulate. Some would argue that in patients who are unstable due to pelvic fracture bleeding, that those patients should go and undergo empiric embolization of their bilateral internal iliacs. Now, there have been reports that patients either that bilateral iliac artery embolization results in gluteal claudication, or even patients can have pelvic necrosis. So what are the issues with angioembolization? This has been used for 30 years. Why would we do something different? Well, first of all, we recognize that only 15% of patients actually have arterial bleeding. So the vast majority of blood loss is due to either venous bleeding or bony bleeding in these patients with massive pelvic fractures. We also recognize that it takes over an hour to set up IR and to actually get your patient into interventional radiology to have angioembolization taken care of. It may not be available at all centers. We're talking about level 1 centers that have a time to angio requirement that can really get this done effectively. And moreover, these patients typically have another reason that they need to go to the operating room. So in patients that you think you need to go and angioembo them, trying to make that decision between IR or OR has historically been very problematic. There was actually a study that was again presented at last year's AAST meeting and just came out in press 2 months ago that showed that this hour to angioembolization in what I would consider one of the finest angioembo centers in the country at Shock Trauma took 5 hours to accomplish. And so here's a patient who is unstable due to a hemorrhage source, and you're not getting them the therapy that they need. And this is, again, at one of the best places that I can think of. And that paper also says that the majority of those patients went on to have a death that was attributed to uncontrolled hemorrhage. So that begs the question, do you want to be in interventional radiology with a bleeding patient? And the rationale for the whole next part of my talk and the reason that we looked into pelvic packing is because this is exactly where I was when patients were dying. And there is no worse feeling than being in radiology, and this is a quote from one of my former partners, of being in radiology and having your patient die on the angio table. That is a bad feeling. And so we sought to do something different. We thought there's got to be another way we can take care of this. Well, out of the European literature, and as some of our faculty traveled to Europe, we had heard this technique described called pelvic packing. It entailed rapid transport of the patient to the operating room. Patients would undergo some type of external bony fixation, either by external fixator or by C-clamp, and then there was direct packing of the retroperitoneum. And so the rationale of that is that you would go and you would directly address the bony and venous bleeding with packs. And then if they needed additional procedures in the operating room, you were there. You could do your fasciotomies, your on-table angio, your long bone fixations, your thoracotomy, your laparotomy, whatever else needed to happen could happen at the same time as pelvic packing. So how do we do this? So number one, the pelvic fixation needs to happen first. Here you can see we used to put these nice large C-clamps on everybody, and they just had, here actually this is one of our chief residents doing it with the orthopedic attending. And again, this nice C-clamp can rock up or down on the patient's torso based upon where the other injuries are that need to be addressed. Alternatively, now the majority of our patients get external fixation. And here you can see this actually was a 6-year-old that had an external fixator placed and pelvic packing performed for an unstable pelvic fracture and for hemorrhage. When you put these external fixators on and you're going to perform pelvic packing, you need to be cognizant of where those bars go. Now, I'm a simple trauma surgeon. I'm not an orthopedic surgeon. They did let me fasten some of the little external fixator pins down there, which was kind of nice of Dr. Stahill. But you want to make sure that you adjust those bars so that you have access to make your incision for your pelvic packing or for your laparotomy. So you want to make sure, you'll see sometimes with those, I call them tinker toys, but you know, you can move those tinker toys, put on extra bars. They can be very complex, but get it out of your way so it doesn't hinder your operative plane. We actually modified the European technique because we really wanted to make sure that we were packing a separate space from the abdominal space. And so when we modified the technique, we described a 6 to 8 centimeter incision. It's carried out from the level of the pubic symphysis cephalad. You divide the midline fascia, and then surprise, on the next slide, surprise, you get into the hematoma. And for surgeons that haven't done this strikes fear, and it actually struck fear in me the first time I did it, because we have been taught over and over again, do not dive into the pelvic hematoma. Patients exsanguinate when you go into the pelvic hematoma. And here I am saying, jump right in there. And the first time that I did it, I was like, this seems like a bad idea. I can't believe I'm going to jump right in there. And sure enough, blood came out like I had not seen in a while. And you dive right in there, you pack the pelvic space, you close it up, and they stabilize. So although it seems heretical somehow, you do need to encounter the pelvic hematoma in order to pack. One of the key things, though, when you pack these patients is you do want to keep your incisions separate. So if you're going to do a laparotomy, you do 2 separate incisions. Here you can see our pelvic packing incision here, and then our big laparotomy incision up top. Same here. You can't see this patient just has an open abdomen that's sort of covered up right before we've taken him back. But here you can see our pelvic packing incision is closed, and he's got a suprapubic tube and a big open abdomen. And here, you can see this, I did major Tinker Toys, right? Like we put so many bars on there, but it got everything totally out of the way, that external fixator frame, so that we could really have access to the abdomen and to the pelvis. So then we perform packing. You've opened that posterior rectus or posterior midline, and you jump into the pelvic space, and then you pack it. When I try to describe packing the pelvis, if you've never packed a pelvis, the best way to see that potential space is actually to go in and scrub with your orthopedic surgeons the next time they plate the symphysis, and you'll be in that potential space, which is really, we describe it as preperitoneal packing, but it's really this preperitoneal paravesical sort of presacral region. It's an upside down U that goes all the way around the bladder. So although it looks, and these pictures, this picture right here is done obviously after the acute phase when we're going back the second time, because there's usually not enough time to take a nice picture. When we go in there, you're really packing, that first pack is all the way around the bladder and down back on the SI joint. So when you go through and you pop into that blood clot, the blood has dissected that entire space that you're going to end up packing. You put your hand on the bladder, pull it over, and that first pack goes all the way down onto the sacrum. The next pack is up on the lateral side of the bladder, and the next pack is up sort of anterior. You pull the bladder to the other side, and you do the same thing on the other side. Typically, you can get about 6 packs in adults. I've gotten up to 9 in patients where we didn't get the pelvis completely reduced with that external fixator frame. And for kids, this works in kids. You saw the 6-year-old that we packed. For about 3 to 4 packs if it's a small child. Here again, you can see it's not really this direction, it's around the bladder is the easiest way to put it. So that sort of inverted U, I think, is a nice way. Here you can see that the preperitoneal space, this is the bladder here in the middle, and we're talking about diving around the bladder on either side. Many of these patients have associated urethral injuries, not surprisingly, and so that's one of the things that when you're in the trauma bay, you want to keep in mind whether or not you're also going to need to put a suprapubic catheter in. It's one of the pivotal points when you're in there packing, because you do not want to leave the operating room without the bladder drained. You don't want to go back into the operating room to go reoperate in that space. You only want to go once. So if they have a urethral injury, either because you've done a single attempt of passing a catheter, or they have blood at the meatus, or whatever your indication is, go ahead and make sure that either you put the SP tube in or urologists are present so that you can go ahead and put those SP catheters in. I like to do them through a separate stab incision. Here you can see sometimes we put it above the packing incision, sometimes lateral to the packing incision, but most of these patients need those SP catheters for quite some time. And then you close the fascia and you close the skin and you head out to the ICU. Simple as that, right? So how did we do with this? Oh, our trigger point. I have to tell you who to go pack first. So we came up with a basic algorithm. Our original algorithm was probably 15 to 20 years ago. And our intervention point for pelvic fracture-related bleeding has been the same. 20 years ago, we went to angioembolization when we had to intervene. Now, when we pull the trigger, we go to packing. And so our trigger point to intervene is 2 units of packed red cells and the patient remains unstable. So it's a pretty significant trigger point. It's not when they first drop their pressure to 90, it's not after the first unit. They have to have 2 units of blood and they remain unstable, and that's our trigger point to go and intervene. As you can see here, if they stabilize, they go on and they get scanned and they go to the ICU. If they remain unstable, that's the patient that goes to the operating room. In the operating room, we not only fixate the pelvis and perform pelvic packing, we also re-ultrasound the abdomen to make sure that we do not need to intervene on the abdomen. If they remain unstable in the operating room, you consider, again, re-imaging the chest, re-looking at the abdomen, making sure you don't have another source of blood loss that needs to get addressed, versus whether or not you need an angiogram, because they fall into that 15% of patients that need an arteriogram and angioembolization. So how are we doing with pelvic packing? I mean, I've given you this great technique. I've said just jump right in there into the bleeding, see how that works out. Is it making a difference? Have we impacted our overall mortality? Well, we think that we have. In the past 11 years, so we adopted this technique 11 years ago, we've taken care of over 2,000 pelvic fracture patients. As I mentioned, very few of these patients fall into that super sick category. So only 6% of our patients fell into this algorithm, received at least 2 units of blood, and remained unstable. So a super select group. The majority were men. The mean age is 44. Their ISS is 48. Very severely injured patients. Their mean emergency department systolic pressure is 74. Their heart rate is 120, and their base deficit is around 12. Although about 40% of patients, we didn't even have time to check a base deficit, I have to admit. What's interesting, though, is that you can see the pelvic fracture classification is across the board. So it's not just these high mechanism APC3s and LC3s, those big mechanisms. It's all fracture patterns. Now, granted, some of those more complex ones, including vertical shear and, this should be combined mechanism, those cull out as probably being at higher risk, but you can have patients with an LC1 or an APC1 pelvic fracture that end up needing pelvic packing. Time to the operating room was 44 minutes, and they actually received 4 units of blood before we got into the operating room. You can see that once they were packed, they really stopped bleeding. So the easiest point for us to measure total transfusion was at the time that they left the operating room. They received 8 units of blood up until that point, and in the next 24 hours after that, they received only 3 additional units. So we really intervened and felt that there was a point at which that packing made a difference. FFP to red cell ratio, because we all know how important it is to transfuse in reasonable ratios, was 1 to 2. Again, I talked about the historic problem of debating whether or not you wanted to be in interventional radiology versus the operating room. All of these patients, or almost all of these patients, 85% of patients needed something else done. And they didn't need just one other thing done, they needed at least 3 other things done. Patients got laparotomies, suprapubic tubes, vascular reconstructions. Here you can see in this bottom picture there were 5 teams operating. Here you see the neurosurgeons. This is a head down here. They're doing a cranie. This is the chief resident with general surgery. This is the urologist. The orthopods are down over here, you don't see them, and then the ophthalmologists were coming in because the patient had an entrapped globe. So you can have multiple patients taking care, multiple services helping to manage these multiply injured patients, and you're not compromising their care and not managing their pelvic fracture related bleeding. So is there a role for angiography? Am I standing up here and saying never send anyone to angio? No, I'm absolutely not saying that. I am saying that pelvic packing helps you determine that 15%, or in our experience, 13% of patients that actually need arterial intervention. For those of you that have been down in the IR suite, that's not the place that you necessarily want your multiply injured patient immediately after a trauma. You really want them in your ICU trying to correct their physiology and restore their physiology. So in our experience, only 13% ended up going on to need angioembolization. The time to angio was about 10 hours. But the interesting thing is packing arrests hemorrhage and halts so that you have that time frame that allows you to restore the patient's physiology before you have to take that trip to IR. So it's not that we couldn't have had our angiographers in. We're like most trauma centers, they have to be there within 30 minutes. But this permitted us some restoration in the ICU before we actually took that trip down to angio. Again, interestingly, the fracture classification of patients that went to angio across the board, but the lateral compression fractures seem to predominate slightly. So how can we predict who needs to go on to angio? We can't, basically. Can't predict it by age, by ISS, their presenting physiology in the emergency department, how much blood they received. The only thing that predicts is how much blood they get post-packing. I guess that's not surprising. If you still have an arterial bleed, you still bleed after you get packed. And so those patients that receive more red cells in the SICU, those are the patients that end up going down and being culled out. So we use that breakpoint to define those patients who actually would be transported out of the ICU down to interventional radiology. So the two things that buy you an angio is, number one, if you remain unstable after pelvic packing, those patients get an angio. Alternatively, if you get transported into the ICU after you are packed, your coagulation status is normalized, and you still require more than 4 units in the first 12 hours, those are the patients that go on for angio. The other patients, if it's less than 4 units, they have nothing at angio that you need to embolize. So here's the word of caution. I mentioned before that there are some known complications of angio. If you send the patient down to angio and you do not see bleeding, don't embolize them, right? If you send someone, and this is not a dig on the IR guys, they're really good at what they do, but if you send them, what are they going to do? They're going to embolize something, right? They'll find something to embolize. So if you send the patient to IR and they don't see something that's bleeding, tell them, I don't want any gel foam, nothing. Just take a look. Just give me a little roadmap. So this was a patient that got sent down, and what did the angiographers do? They embolized him, right? They said, well, you sent him to us. We embolized his bilateral internal iliacs. We thought that's what you wanted. And the patient didn't have any evidence of extrav. Well, look what happened. He actually ended up with this perineal necrosis, or this rectal necrosis that's described. And I can tell you this was just within the last year, really not fun to deal with. He survived, and he had a lot of wound issues. I'll just leave it at that. So if you send them, make sure that you're very clear with your angiographers what you would like to have accomplished. Removal of the pelvic packing. We unpack patients based upon our sort of experience with liver packs. We take them out at about 24 to 48 hours. In our first series of patients after that first 5 years, we looked at our infection rates of the pelvic space. And one of the things that we recognize is that in those patients that only undergo 1 round of packing, the infection rate is about 6%. If you get 2 rounds of packing, so you go back to the operating room, you unpack them, you go, oh my gosh, it's still bleeding in there, and you put the packs back in, those patients had almost a 50% rate of infection. So we learned from that you don't take them back for unpacking until they really have stabilized and they don't need any more blood transfusions. Additionally, when you take them back, you make sure that you do topical hemostasis. You put, flow seal in, you bovie some stuff, you stitch some stuff, you take care of small bleeders, you put some clips on, but you need to control any of that pelvic space hemorrhage on that first take back. In the past 5 years, repacking has happened twice in our group. The lessons that I've learned is, number one, don't let orthopedics take them back by themselves. Because what happens? They see blood, and what do? They pack, and then they call you and they say, hey, Clay, it was bleeding in there. I put the packs back in. You can take them back tomorrow. Well, what just happened? My infection rate went from 6% to 47%. And so, as I mentioned, you really want to go in with them and identify the bleeding. Now, so we've had 2 patients. So what are the odds that one of those 2 patients should have gotten infected, right? 50% get an infection. So this is completely, I have no data to support this. This is purely just something that I tried because it sounded like a good idea. This is adopted from the vascular sort of practice of infected grafts. Seemed like a good idea. So what they do is they put this little slurry together of rifampin and tobramycin. They put it in 30 cc's. Here you can see we're putting it, there's our external fixator, and we're just putting that slurry down in the pelvic space because the patient has now been packed twice. And an infection of the pelvic space is not something I want to have happen for either of those 2 patients. Well, guess what? Neither of them got infected. So do I think this is a fabulous idea? I'm considering it, and at least one of those 2 patients that should have gotten an infection didn't get an infection. So how are we doing? The whole point of this is, what's our mortality rate? All pelvic fractures, all comers, our mortality rate is 8%. That's very common in the literature. It's between 6 and 10%. In this high-risk group, it's 21%. Now, if you look, if you keep up with the pelvic fracture literature, similar series, modern day series published in the last 3 years, show mortality rates between 30 and 40%. So we actually feel that with a very severely ill and injured population, we actually have a reduction in mortality in this group of patients. So let's look at the patients that we could have done differently. So traumatic brain injury, probably that falls into that 30% that we can't do much about. Multiple organ failure, could we have reduced our bleeding? Possibly. But really the adverse physiology group, are these patients dying of acute blood loss? That's the group that we still are trying to target. How could we do better? So in these 3 patients that had early deaths, 2 of them died within 100 minutes, which is pretty quick to get someone taken care of. And they went into just DIC and they died on the operating room table. But 1 died within 9 hours after arrival because we could not reverse the patient's physiology. And for those of you that take care of these sick patients, sometimes you get into that vicious triad and you cannot get them to reverse. So was there a way that we could intervene on these patients earlier, and maybe even in those MOF patients? So we've started using REBOA, and I'm not sure if there's going to be a REBOA talk at this, so this may be my 2 minutes of REBOA conversation. We now, on patients that have hemodynamic instability, so if they have a systolic pressure less than 90, we go ahead and put an arterial sheath in that would give us access to place a REBOA catheter if they drop their pressure further. So particularly in pelvic fracture patients, this is sort of the one caveat of patients that I think the literature is becoming fairly clear that placing a REBOA in these patients for temporary aortic occlusion can be very helpful. So in these patients that have a systolic less than 80, we place a REBOA catheter and we take them to the operating room if that's the next step. For those that know about REBOA, this is the initial studies came out. I mean, this is a very old technique that now has sort of been revitalized in the last 5 years and has become very sort of nouveau and kind of exciting. And now lots of papers are coming out. This was one of the first descriptions that Todd put out. Here you can actually see a patient with this nice pelvic binder. They came in from an outside hospital. And this is the old catheters that we used to use with the coda balloon that you can see. And these catheters were a little problematic because the sheath was long. It had to stick out of the body. But here you can see the sheath coming in, and here's our balloon up here that's providing aortic tamponade or control right above the bifurcation. In general, the REBOA came out. There were 3 or 4 papers that came out and said, yes, REBOA is terrific. Then, of course, what happens? You get a paper that says, not so sure about REBOA, right? And in this paper specifically, there was the group thought that there was a higher mortality rate. Now, you could say it's not the same group. There's always comparisons. And what's interesting is some of the issues that were raised in that paper and that we saw as well is that these large sheaths, here you can see one of the catheters that I took out of a femoral artery, these large sheaths, you had to go back in and do an operative closure of the femoral artery. And so how many patients ended up with ischemic complications or embolic complications related to these large sheaths, and moreover needed operative removal of the sheaths, I think was a little bit problematic. Now, however, there's a newer catheter, and here you can see this is me, obviously, and here's this nice catheter, and it's a lower profile catheter. It's a 7 French arterial sheath, and you can put the balloon in, and it's a lower profile catheter that you can put in, and you simply check a film at the bedside. And so this is easily put in at the bedside, and I think could potentially revolutionize how we care for these very, very ill patients in the emergency department and turn the tide on these patients. This is a specific case. Here you can see this patient came in. He was run over by a cement truck. He was one of those flaggers at a workplace. He clearly, I mean, that's not even a subtle perineal degloving injury, right? He came in, his pressure was 50 in the emergency department. I put the REBOA up. I think this is my cheap man's version. Oh yeah, here you can see, sorry, my cheap man's cell phone, you know, on the portable thing. There you can see the REBOA catheter is up and it's providing aortic occlusion. We took him rapidly upstairs. He got his Tinker toys put on. He got his pelvic packing. We ended up, the wound became an issue for the next 2 months, but we ended up controlling the local bleeding in the wound with some packing. We took the REBOA out. It was out at about an hour, and the patient ended up walking out of the hospital at the 2-month mark. So I think that this is a significant addition to our armamentarium, and I think that pelvic fractures, these very ill pelvic fracture patients, you need that armamentarium in order to take care of them. So thank you very much for your attention this morning, and I'd be happy to answer any questions.